Now that you're fueled, put on your seatbelts because we are about to cover 3 hours of neuroscience research in 20 minutes. And no one is better equipped to lead us on this adventure than our next presenter, Jonathan Buchholz. So I'm going to turn it over to you, Jonathan, to introduce yourself and to start our journey. Thank you.
Hi there. That's it's hard to live up to there. I appreciate that. Thank you for having me. I'm Jonathan Buchholz. I'm an addiction psychiatrist by training, and I do the most of my clinical work on the acute care service at the VA in Seattle, where I've been taking care of folks with co-occurring substance use and mental health disorders for the better part of 10 years. I'm the director of the addiction inpatient consult service for us here at the VA, and then I also am the director of the Addiction Psychiatry Fellowship at the University of Washington. Are you going to run my slides for me, by the way?
Yep, exactly.
Awesome. Okay, so next slide.
Take your cues. Yep.
Wonderful. All right. So I do have to disclose I did get an honorarium from Indivior Pharmaceuticals for a non-branded discussion of substance use disorder, particularly opioid use disorder and treatment of veterans in March this year. Next. So today what we're going to do is I am going to talk about medications for amphetamine use disorder or methamphetamine in general. I'm not going to get into the specifics about treatment of specialized areas like psychosis or protracted depression and things like that. This will be really focused on medications that have evidence for the treatment of amphetamine use disorder. I'm going to start with high-level stuff with systematic reviews and meta-analysis, and then I'm going to talk to you about some individual medications that have shown some promise. But what I really also am very interested in, and I really appreciate the structure of the day today in being able to discuss questions that folks have, because the truth of the matter is we don't have fantastic medications that work as well as medications for opioid use disorder. All right, so next slide. So very basic overview here of methamphetamine neurotoxicity. And again, I'm not going to get into the weeds with folks here, but I do want to set some ground, sort of set the stage, some ground rules for like what is happening in the brain. So methamphetamine has expansive neurotoxicity, leading to neuronal damage. But as we have heard in multiple ways, methamphetamine is so highly dopaminergic that it leads to changes in dopaminergic nerve terminals and expression of dopamine at the transporter level. And those derangements, depending on the study that you look at, can last for a very long period of time, up to 14 months or even longer at times. And because of this, we actually have quite a few hurdles when we're trying to take care of folks who have experience with amphetamine use disorder. And so that informs why some of these medications have potential, but why we also have not had a magic bullet medication as closely related to buprenorphine and methadone for opioid use disorder. Furthermore, the dopamine system works very differently than the mu-opioid system, and where you can saturate mu-opioid receptors with opioids and sort of not achieve much more stimulation of the actual dopamine receptor. That doesn't occur with dopamine, and amphetamines are notorious, particularly methamphetamine, for being so highly rewarding that it's very difficult to actually have a medication that comes close to achieving that same level of reward. Unfortunately, also what happens is you get quite a bit of behavioral changes that can occur So this doesn't occur just in one area of the brain. There's quite a few areas which involve dopamine, frontal cortex, hippocampus, striatum. And though serotonin is involved, it's not really the primary neurotransmitter that we really think about damaged by amphetamines. All right, so next slide. So there are no FDA-approved medications for the treatment of amphetamine use disorder. There have been a number of different medications that have been tried, and so you can see over here on the right the medicines that have been attempted in the past. So the way that I'm breaking it down today and talking to you all is, what do we know about these sort of categories of medicines: psychostimulants, naltrexone, mirtazapine, and bupropion plus naltrexone. I'm not going to get into all the details of these other medications, mostly because we don't have time, and because, quite frankly, I sort of eliminated the stuff that isn't terribly effective. So next slide. So this was a meta-analysis that was done in 2020 by a group that took a look at both cocaine and amphetamine use disorder trials. This was a systematic review and meta-analysis. And so with that, they actually had a pretty good sample size of almost 2,900 patients. They limited it to randomized double-blind placebo-controlled trials and looked at both cocaine and amphetamines. I'm only showing you one forest plot out of the very comprehensive systematic review. This one is specifically about engagement, and what you can see here is that cocaine and amphetamine, when pooled together, actually aren't improved by giving a patient a psychostimulant. With that said, one of the limitations of this study was that they also included modafinil and bupropion as in the category of a psychostimulant as a treatment. And so some of these studies are not being are not using actual stimulants or amphetamine-like stimulants. And so so there, you have to take this meta-analysis and systematic review with a grain of salt. So next slide is an updated version that actually removed modafinil and bupropion. And so the number of patients significantly reduces here, but it really is looking specifically, and this was last year, this meta-analysis and systematic review, showed that there were not really great statistically significant differences on the initial comparisons when it came to use of stimulants, when it came to consecutive urines for folks, when it came to overall quality of treatment engagement. And at the same time, there were some subspecialty areas that did improve, particularly those patients who had ADHD. And so one of the subgroup analyses here showed that actually high dose methylphenidate, more than 162 milligrams, was actually superior to low dose methylphenidate or dextroamphetamine, in that it reduced the number of UA positives for amphetamines and it improved engagement in treatment. That's a pretty subspecialized population and actually makes a whole lot of clinical sense. The downside to this data is, typically speaking, when we are actually treating patients for ADHD, we are using smaller doses. So ADHD typically max dose is 108 milligrams for methylphenidate, 50 milligrams for dextroamphetamine. And so if a patient does have ADHD and is potentially a candidate for stimulant treatment, they may actually need higher doses. And you have to take all of this with a grain of salt because these are, again, subspecialized studies. Next. So Naltrexone for methamphetamine is a treatment that has been attempted in a variety of different ways. This is one of the positive studies showing the percentage of negative urine samples was improved slightly with the treatment of naltrexone amongst 80 patients. Which is promising information, and actually led to a trial that we'll talk about here in a second. But you can go to the next slide. So aside from naltrexone, mirtazapine actually has 2 trials that have shown some improvements to amphetamine positive urines. And that is a group that actually is out of San Francisco with uh, similar designs, but essentially showing in 2 separate patient populations the potential for mirtazapine to actually improve amphetamine use disorder. So 2011, you see they gave 30 milligrams of mirtazapine to folks who had amphetamine use disorder, and their urine samples reduced over 12 weeks. What I think was also encouraging about that study is the engagement was pretty remarkable. So the second study by Coffin in the same group showed specifically at 2 time points reductions in urine positive drug screen. So if you look at the next slide here, it'll show you that specific time frame. And so mirtazapine is really interesting in that when you look at the sort of discussion and comments and how this might be useful, one of the things that kind of comes up in both of these studies is the potential improvements in terms of mood and quality of life and ability to sleep and appetite. And so it's not just the medicine for amphetamine use disorder. There's some other benefits that are secondary and not necessarily specifically related to just amphetamine use. The next slide. So this is the most, I think, recent study taking a look at this novel approach to amphetamine use disorder using bupropion and naltrexone. So this came out a few years ago. 400 participants, randomized double-blind trial. And they had a really interesting model where they did this sequential parallel comparison design, which I'll show you here in a second. But essentially, the sort of 30,000-foot view of this is that during the trial, which is 12 weeks, the folks who were on bupropion and naltrexone had an improvement in the percentage of number of urine negative drug screens, at least 3 out of the 12-week period of time. And so it's a very specific measure in looking at over 12 weeks, how many times did you have a negative urine trial, 3 out of 4 samples at the end of the week. So very specific, but did actually show some improvement. So you can see 13.6% of the treatment group versus 2.5% of the placebo group had at least 3 methamphetamine negative urine samples out of 4 by the end of the 6-week trial. So the number needed to treat here is 9, but the actual impact of it can be discussed. How much is this actually efficacious for patients? And one of the critiques that I have personally on this treatment approach is actually the number of side effects that patients described who are in the treatment group. And not a small amount of folks had gastrointestinal complaints, tremor, malaise, and the actual adherence to treatment in terms of medication compliance was less in the treatment group than in the placebo group. So I'll show you the last slide here about the bupropion naltrexone, which shows how they sort of did this. So if you look at the first graph there on the left, naltrexone and bupropion is the treatment group, placebo below, and you'll notice that they actually randomized 200 people to the placebo group in the beginning, planning such that what would happen is if the folks in the placebo group did not have a response, they were then re-randomized. And so you can see in the second portion of that graph, looking at those in the purple who were first on placebo and then went to naltrexone bupropion, or were first on placebo and then got placebo again. So there's a little bit of a difference there with the folks who initially had placebo and then transferred to the naltrexone and bupropion. All right, next. Okay, perfect. So these are my references, and I intentionally decided to make this as short as humanly possible, because what you have is really the best evidence for medications for amphetamine use disorder. I'm glad to go into any of the details of these studies or talk about other studies, and get feedback and or discuss this. But the truth of the matter is we don't have fantastic medications. With opioid use disorder, if you start a patient on buprenorphine or you stabilize someone on methadone, their all-cause mortality reduces by 50%. These medications, we just do not have that same level of evidence or data. There are several caveats to some of the medications and how do you actually choose medications and what do you do. I typically will look at other factors for a patient, what is going on with them in terms of other mental health issues, potentially depression, anxiety, mirtazapine rises to the top. Someone who has co-occurring problems with alcohol and amphetamine, naltrexone may be useful. Those who are really sluggish with lots of difficulty with concentration and depression maybe actually would be a candidate for the bupropion naltrexone. As a psychiatrist, I worry a little bit about the 450 milligram dose of bupropion being tolerated in some of these patients, but uh, uh, overall, it was fairly safe. So I would like to open it up for questions and discussion. Um,
So Jonathan, if you're able to look in the Q&A
there we go.
at the
Yeah.
bottom, if you scroll to the bottom, there are a couple of questions there for you, starting with Jeremy.
All right, this is a wonderful question. So I'm wondering about a combination of mirtazapine and semaglutides to combat weight gain following stopping meth that is often compounded by the side effects of taking mirtazapine. My understanding semaglutides is being investigated for cravings, and when I heard this, it sounded like a way to mitigate physical and emotional triggers. Um, and it was helpful to Jeremy. Wonderful comment and really interesting. So semaglutides are being investigated for all sorts of substance use disorders currently, and seem to be getting some pretty good traction. It is not approved, and I'm not actually aware of any healthcare provider or excuse me, health insurers covering it. Um, but it's not a bad idea. Semaglutides are an interesting medication that has some promise. I don't think that we could necessarily prescribe it at this point with the data that we have. The other thing that I always tell people about mirtazapine is that most of the weight gain actually occurs because of the hunger that people have precipitated by taking the pill. So usually, and this may not be the experience for Jeremy, but usually weight gain for mirtazapine is driven by the hunger and the appetite increase and the actual food intake, as opposed to the actual medicine causing weight gain, which can happen with things like olanzapine or other medications. Um, did that answer the yes, you were yes. Nighttime eating is unfortunately quite a side effect for some people. And it's a real issue when you're talking to somebody who that might actually not be a helpful thing for. Okay, so what are the effects if someone uses methamphetamine while taking these medications? So generally speaking, I want a patient, I'm going to start a medicine for a patient that I feel like they can take if they're also taking amphetamines. I'm not um I always will tell people the risks and benefits, but it's hard. I think for me to feel good about giving a medication to someone who uses amphetamines regularly, whose goal may not be completely stopping. If it is that their goal is completely stopping, we can talk about that. But I don't have a concern about any of these medications. The only thing is when you do mix amphetamines, so if you were to prescribe an amphetamine to a person and they were to continue taking methamphetamine, it's just synergistic in terms of risk for cardiovascular disease, risk for weight loss, risk for anxiety and ongoing perceptual disturbances. But it would not be um, uh, a contraindication to take the medicine. Okay, what else do we have next? What's next?
Is there any research exploring the use of fecal microbiota to transplants to treat stimulant use disorder, similar to how it's been studied for alcohol use disorder?
All right.
Great questions you're getting today, I'll tell
So
you.
that's an amazing question. I don't know the answer to that. I will also say that um, the um, any sort of uh, non-pharmaceutical study um, uh, will have a more difficult time reaching evidence base. With that said, I just haven't read any studies about the fecal bacterial transplants in stimulants. I did actually see that study regarding the alcohol use. So um, I can't comment on it. I'm sorry. If someone else knows, I'd love to hear their thoughts.
Okay, we have another question about psychotropic medications and psychosis, but I'm going to hold on that because we're going to talk about that in our final session today.
Okay.
And I will ask any updates on methamphetamine vaccine research.
That's the timing is wonderful. So I talked with Dr. Pravatoni yesterday. So Michael Pravatoni is one of our researchers here at UW, and there's been a lot of work on vaccines for both cocaine and amphetamines, and um, the evidence for how a human responds to the vaccines is not as good as animal studies have shown, and that's generally been um, sort of the limiting factor in us taking this a little bit further and actually potentially creating a vaccine that would be available to the public in wide distribution. Um, and so yes, they're continuing to look at that. I have not actually seen a vaccine with great human trials with lots of robust evidence that make me very convinced that this is going to be a near future treatment.
Okay, next question. Any considerations you bring to evaluation of concurrent conditions while someone is actively using or who has recently interrupted use? What factors do you consider?
Yeah, so I'm a trained psychiatrist, so I always think of people in the context of their life story. And so I try as much as I can to consider where they're at, both from a psychosocial, mental health, overall quality of health sort of standpoint. And I think you see people in all phases of their life, and you absolutely have to take that into account when you're deciding and working with somebody about where to start and how to come together to start of working with them in whatever path toward recovery or moving forward they have.
Okay, and final question in the chat, and this is last call for any questions as we get close to the end of our session here. So we had somebody who was listening to somebody who uses meth on a podcast the other day who said that Sublocade had worked for them. Any thoughts about that?
Yeah, so there is some emerging evidence looking at folks who are using both opioids and amphetamines, and showing that amphetamine use can actually improve if someone gets stabilized on opioid treatment, and that has several different trials, both with methadone and with buprenorphine and Sublocade, kind of showing this, but but the actual sort of Sublocade for amphetamines, to my knowledge, actually has not been researched yet. And so, biochemically, if someone had both disorders, I could definitely see an argument for it. There are folks who are reaching for it to see if it's potentially helpful, with the argument of, well, maybe this will also protect the patient from an unintentional opioid overdose if they got fentanyl in their drug supply. And it for me, someone who is using amphetamines, starting them on Sublocade if they don't have an opioid use disorder, the downside of that is, you are actually exposing somebody to a medicine that they will be dependent on, right? So physiologic dependence, if you take Sublocade, it will require your body to come off of the medication and potentially have withdrawal symptoms. And so I hesitate a little bit on that. And at the same time, I'm certainly not opposed to it for someone with OUD. We would definitely want that, but someone who has tried lots of things, I could potentially think about it. I just don't know that there's data to support it at this point.
And I, as your moderator, am going to give myself the privilege of asking the last question, which is, we hear this phrase, there are no treatment medications for stimulant use disorder, which often gets heard as there is no treatment for stimulant use disorder. And it often then gets internalized by people who are looking for help as, I cannot be helped.
Yep.
So what messages can we offer, and what do you as a provider offer as a counter argument to this?
Yeah, so as a psychiatrist and known drug pusher, I I I always want people to understand that the word treatment is not synonymous with medication, and that many actually of our um, uh, uh, patients who experience substance use disorders get into recovery without the use of any medicine ever. And so what we need to do, and what I try to do with patients, is actually be evidence-based and say what is effective. And we have a terribly effective set of of therapies that work really, really well. And one of them is contingency management. And I am a huge proponent of us improving access to contingency management and spending a lot of energy and time trying to make that happen, because it works and we know it works. And I actually would love to see contingency management and medication management work in tandem, and actually studies to continue taking a look at whether or not adding contingencies with medications and psychosocial intervention might be useful. But I very much tell folks that we can try medications, and I don't say that they're completely useless. I say, like, there is some evidence here, but we also want to help you in terms of getting into therapies that might be useful for you.
Well, that is a perfect segue to our next session on contingency management. So thank you for that very perfect exit and on-ramp to that next conversation. Thank you so much again, Jonathan, for joining us today. And we will take a break and be back at 1:20 to talk about contingency management. Thank you.